Hello everyone, nice to see you after a long time. Today we'll be discussing pineocytomas. The outline of today's talk includes introduction, clinical features, imaging findings of pineocytomas and its differential diagnosis, the macroscopic and the microscopic findings. In the histology or the microscopic findings, we will be discussing how to differentiate normal pineal gland versus the pineal parenchymal tumors, that is pineocytomas and the pineal parenchymal tumor of intermediate differentiation. Then we will discuss immunohistochemistry, genetic profile, and prognosis. Introduction. The pineal gland was described as seat of the soul by René Descartes, and it is located in the center of the brain at the rear end of the third ventricle. This gland is responsible for secretion of melatonin, which maintains our circadian clock. Now, the tumors arising in the pineal region could originate from the pineal gland, that is the pineal parenchyma, or from the other structures in the pineal. What could be the masses in the pineal region? First is the pineal gland tumors. These are the primary tumors of the pineal glands, that is arising from the pineal parenchyma, such as pineocytomas, pineal parenchymal tumor of intermediate differentiation, and the pineoblastomas. Now, pineal gland tumors as such are very rare. The second is the papillary tumor of the pineal region, which account for 15 to 30%. Next is the germ cell tumors, which account for 40% of the tumors in the pineal region. Fourth is the desmoplastic myxoid tumor of the pineal region. Next is metastatic tumors, the non-neoplastic lesions such as the pineal cyst. One should not forget diffuse midline glioma because the location of the pineal gland is in the center or the midline. So one must always take into account the diffuse midline glioma. And lastly is the meningiomas. Now coming to pineocytomas, these account for less than 1% of all intracranial tumors, and these are rare, as I said. They account for almost 20% of all pineal parenchymal tumors, more commonly found in female, and these can occur at any age, but the mean age is 35 to 40 years, that is, adults are affected. Clinical features. Signs and symptoms of raised intracranial tension, neuroophthalmic, that is the Perrinot syndrome, which is caused by compression of underlying tactile plate, which causes triad of impaired upward gaze, convergence retraction nystagmus, and pupillary hyporeflexia. Ataxia and other symptoms such as headache, papilledema, impaired vision, nausea, and vomiting. Imaging findings of pineocytoma. On MRI, these appear as well-circumscribed round pineal mass, usually less than 3 centimeters, and may be seen causing compression over the adjacent structures. Now, as I said, less than 3 centimeters, when the size is more than 3 centimeters, one should suspect a high-grade tumor, that is a pineoblastoma. So these are hypo-intense on T1 weighted images and hyper-intense on T2 weighted images. On CT scan, typical peripheral calcification is best appreciated. On post-contrast, T1 weighted images, strong homogeneous enhancement that could be either solid or peripheral is noted. It may cause aqueduct compression leading to hydrocephalus. A cystic mass may show fluid level and a nodular tumor along the periphery of the mass. Now, one must take into account the differential diagnosis such as pineoblastomas, pineal cysts, germinomas, tactile plate gliomas, and the meningiomas. So the pineal cysts, these are non-neoplastic lesions and may be indistinguishable from the pineocytomas with cystic degeneration. The cyst is usually 1 to 2 centimeters in size, and these are solid cystic masses with presence of cystic fluid. Now, pineoblastomas are more than 3 centimeters in size. These are less circumscribed masses and are commonly found in younger males. The next DD you should remember is the germinomas. Now, the germinoma usually engulfs the calcified pineal gland. These are homogeneous and intensely enhancing, typically found in young male patients, and they may show CSF spread may or may not be present. One should also take into consideration the clinical profile such as the germ cell markers, that is alpha fetoprotein, beta HCG levels. Now all these markers will be absent in case of pineocytomas. Next DD is meningiomas. These are avidly enhancing homogeneous masses with the dural tail, and these are usually found in the middle-aged women. Now we'll be seeing MRI of two cases of two patients. I've included these two cases in my book. So the case one, this is a 41-year-old industrialist who presented with headache, nausea, and inability to make upward gaze. So this is MRI of this 41-year-old industrialist, and this is a T2 axial and the flare coronal images. And you can see a well circumscribed or a well defined rounded mass in the pineal gland. And here you can see a small internal septation. Now, this is a second case of a 38-year-old man who presented with headache, nausea, vomiting, and visual disturbances. Now, you can see this brightly enhancing mass in the pineal gland causing hydrocephalus, and this is the sagittal section. So, on gross examination, these are well circumscribed, gray tan tumors in the pineal region. The cut section appears homogeneous and granular. Coming to histology of pineocytomas, these are CNS WHO grade 1 tumors. And before that, we'll have a look. The normal pineal gland has well-defined lobular architecture. Now, these pinealocytes are separated by strands of connective tissue along with loose neuroglial stroma. Now, the pineocytomas may have lobules, but these are usually ill-defined or poorly defined. And the pineocytomatous rosettes are absent in the normal pineal gland. Now, it is also important to differentiate the normal pineal gland from the pineal parenchymal tumor of the intermediate differentiation. Coming to histology of the pineocytomas, so these are moderately cellular tumors, and there are sheets of neoplastic cells, and sometimes they are in poorly formed defined lobules, often separated by large pineocytomatous rosettes. You can see the cells are relatively small, uniform. These resemble pinealocytes, and these nuclei are round to oval with inconspicuous nucleoli and finely dispersed chromatin. The cytoplasm is moderate in amount and it is quite homogeneous. You can see that, see, these are the typical pineocytomatous rosettes. These are large, loose homerite-like rosettes with central fibrillary zones or the enucleate zones, which are formed by delicate tumor processes. And these resemble a neuropil. Now, these are surrounded by small, round tumor cells. There is no nuclear pleomorphism, mitotic activity, microvascular proliferation in the grade 1 pineocytomas. Microcalcification may be present. Now, this is a high power view. You can see how uniform the nuclei are. and there's no mitotic activity or nuclear pleomorphism. The chromatin is finely dispersed. One should differentiate pineal cyst from a calcified pineal gland with cystic degeneration. Now, other features in a pineocytoma could be presence of gangliocytic differentiation. So you can see these are the ganglion-like cells present in the pineocytomas. A differential diagnosis of ganglioglioma. Yeah. So next is the pleomorphic variant of the pineocytomas, and these are composed of multinucleated tumor giant cells and bizarre cells. You can see these are the pineocytomatous rosettes. However, there is no mitotic activity found or necrosis found in such cases. I've borrowed this slide from my teacher, Dr. Mark Rosenblum from Memorial Sloan Kettering. Pineocytomas show strong immunoreactivity for synaptophysin. Now you can see the pineocytoma cells are positive. This is the neuropil which exhibits strong positivity. Even chromogranin A is positive here. The Ki67 proliferation index is low. It is usually less than 1% in pineocytomas. So this diagnosis is given as Pineocytoma CNS WHO grade 1. Coming to genetic profile, there is no specific genetic alteration, but these tumors do have a distinct methylation profile. Prognosis, these are stable or slow growing tumors with 5-year survival rate of 86 to 91%. The most important factor is the extent of surgical resection. These are rarely complicated by hemorrhages. Now, what you must know about pineocytomas is the classification of the pineal gland tumors. You must know the grade, how to interpret imaging findings, the macroscopic and the microscopic findings, immunoprofile, molecular genetics, and prognosis. Take-home message. Pineocytomas are CNS WHO grade 1 tumors. These are usually less than 3 centimeters in size, but whenever the size is more, it exceeds 3 centimeters, you must think about pineoblastomas. On imaging, these are well circumscribed round or globular masses in the pineal gland, which are T1 hypointense and T2 hyperintense. Peripheral calcification is best appreciated on CT scan. On histopathology, the tumor is composed of sheets of uniform round to oval cells which resemble pinealocytes, and Pineocytomatous rosettes are also present. The nuclei are round to oval with inconspicuous nucleoli and moderate amount of homogeneously eosinophilic cytoplasm. Nuclear pleomorphism or mitotic activity is absent. Microcalcification may be present. Necrosis and microvascular proliferation is absent. Synaptophysin is strongly positive in tumor cells and in the pineocytomatous rosettes. Now, the variants could show pleomorphic or bizarre cells, and there could be gangliocytic differentiation. Now, these gangliocytic cells are new and positive, whereas new and negativity is seen in the pineocytoma cells. In molecular genetics, these tumors do not show any recurrent genetic alteration, but they do have a distinct DNA methylation profile. The prognosis is good and depends on the surgical extent. So, thank you very much. I hope you all liked this discussion on pineocytomas. If you have any interesting case, please let me know on my email ID. I would be very happy to discuss it. Thank you very much.